horizontal as well as they are all acceptable. Cover them with antibiotics and you'll be okay. Next slide. So, as we conclude, preventive obstetric care is what can actually prevent a lot of these emergencies that we are talking about. In fact, there is now a concept that is known as preconception care that you apply to the woman even right from their teenage age. And for many of us that are practicing in the rural area, they know us, we know them. So your care for these women starts from even their school age and their teenage years, as you counsel them on nutrition, their care of themselves, they are ensuring that they know how to prevent teenage pregnancies, which can create problem for them, and then to book early if they get pregnant, so that the antenatal care can be taken care done for them early. And then for any of this one, early detection of the problem is the key. Is it hypertension? If it's detected early, you can always solve the problem. Is it that the baby is bigger than expected, macrosomy baby, twin pregnancy? In modern obstetric care, high risk pregnancies as well as low risk pregnancies are determined right from the booking, and we must be able to know that. We must be able to do like my surgeon that we work together for several years. He will always say that the jumbo jet is flown by two pilots, the pilot and the co-pilot. Both of them are very skillful. There is no oga, there is no omanche. Any of them can fly. Wherever we are practicing, let's always know that when we have very high risk, very difficult cases, don't let us play hero. Let us call our colleagues together and face whenever there is challenges, so that we can always solve this problem. And then, as I said earlier on, emergency preparedness is what is needed in most of our centers, even in the rural place. Nothing is wrong in your ensuring that in the center, whatever is going to be used for emergency is already known, and when emergency come, they can pick the tray, they can pick the bucket. In some of the practices that I supervise, we know that they will say tray. Well, good tray, but in some of the practices we use bucket. We keep the IV fluid, we keep the giving set, blood giving set, cannula, everything is in the bucket and is already packed sufficient. Label emergency. Emergency is coming, you pick the bucket and you come to where you are going to take care of the woman. Everything is there, and within 5-10 minutes, you've already gotten the woman ready. Whether you are to go to theater, whether you are going to transfer, whatever you are to do, whether you are to call to your colleague, you are ready to do all of that. So emergency preparedness is one of the things that can save the day in any center, in anywhere. It can be my village in Iboloyin, it can be here in Isenyin, or even other rural places more than here. And we know that the rural surgeon will always continue to be known that is not afraid of any situation. And when there are situations that we need to transfer, that we need to work on together, let us recognize them on time and do the needful. Thank you very much once again for the opportunity.
Thank you, sir. Please, another round of applause for our guest lecturer, who has judiciously done justice to the topic given, obstetrics emergency in rural surgical practice. Once again, on behalf of our chairman, Dr. So during the course of the lectures, I know something might have been running through our mind in terms of questions, clarification, or possible contribution. So the floor is open. Because of time, we are going to entertain, let's say, two or three people so that we can move to the next thing on the agenda. Thank you. So, our guy.
Thank you, my dear friend, lecturer. Uh, can for you to see that. Thank you very much, sir. Well, I know Dr. Okedare is experienced when we started in those days. In fact, we started that you've not lost any of your patients. Thank you very much.
Oh, you said you want two or three. Maybe all of them.
Any other question?
Well, I want to join Baba Ojo to thank our Oga. We call him Oga Okedari, or we call him Baba Okedari in the faculty because of the wealth of experience that he has. Thank you very much for those exposition. My comment is related to Baba Ojo's comment vis-a-vis classical incision or T-shaped incision. Because I've seen somebody ruptured at 26 weeks. And the comment I want you to make is what is the current Because I have come across where people say, if you have reason to do classical, then you must do BTL. That if you have reason to do classical incision, then you must do BTL. Or if you have reason to repair a ruptured uterus and you are not able to remove that uterus, then you must do a BTL. Exactly because of what Baba said. We know the challenges we face in this area. You can't be sure that that woman will get to the hospital during the next pregnancy in good time because of all the challenges, especially in our rural community. And so I want you to comment on this. The other issue is, well, maybe this is just with the addition. When we are using magnesium sulfate, in the rural area we may not have access to monitoring the level of the magnesium or whatever. Simple knee jack will be sufficient for us to say that, oh, this patient that is deteriorating may not be deteriorating from the primary thing, but may be from the magnesium sulfate. So these are some of the things that we should be on the lookout for. Thank you very much, sir, for the lecture.
Thank you. Any other? Ah. Shall we- Okay. My chairman, permission to give to Dr. J.
I just this classical and the problems that leads to classical incision. I maybe because my own hand is small. Yeah, the instances that leads using classical, like the deeply impacted head. I've been managing somewhat with internal podalic version. I don't know if it's acceptable.
My chairman.
Well, thank you, sir, for the lecture. My question is that it's when you have we have patients who have obstructed labor, especially CPD, and the so deeply impacted, and for some of us that actually we don't have a lot of experience, and the other thing now is that if one finds it difficult to get to the head, you understand, below the head to deliver the baby, one might just simply just attempt to deliver it by breech. I think that could, if someone could do that one, that could also be life-saving. The other thing is that it has to do with shoulder dystocia, which is a dire emergency that could really be distressing. I don't know whether I can just talk a little about it, sir. Thank you.
Okay. I want to appreciate you for the presentation. My question is, when PPH becomes stubborn and you have tried all your best, to resolve it and it's not resolving, is there any reason for us to intervene surgically? Is there any? That is first question. Then the second one is that there was a finding, a research some few years ago, that there is this special suturing that you can just tie the uterus. I don't know whether those people are from the Edo State or the East. You didn't mention that it's special, and by the time you now apply that suturing, all this will just. Then the third one is just a suggestion. We're talking of early referral. That is early booking and like in order to prevent morbidity and mortality of this thing. Don't you think that it's necessary for us to educate all those traditional birth attendants, all those people at the local government that first of all, because most of these pregnant people, they visit them, they kind of patronize them more than us. And it's like, I don't know whether the government is doing anything in order to really do something about that, because late referral is one of the what is causing the whole world. By that they now presenting to the doctor, the whole thing has kind of turned somehow. Thank you.
Thank you very much, sir, for the lecture. My question is still on fibroid in pregnancy. What we all know is that it's very, very risky trying to remove the fibroid as surgery. But then, what do we do when you have a very big fibroid that actually covered your the anterior part of the uterus, and you still want to go in and you cannot even place your incision? Thank you.
I think that's the last one.
Thank you very much. I'll be very brief. Classical incision. Honestly speaking, classical incision that we had ruptured with, I'm sure they were in the days and they were possibly done by people who didn't have the right surgical skill. Now, let me illustrate what happens in this present age. Now, if you for any reason, as we said, it is no more acceptable. But if peradventure you find yourself having to do it, let me give you 1, 2, 3 personal advice that are surgical. Number one is that you do not plan that you will repair the upper segment of the uterus in 2 layers. It will be a taboo. As many of us as work on the uterus, we know that those layers there can never be well repaired in 2 layers. In fact, if you want to do very well, you will repair a minimum of 3 layers. And you see, if you've done a lot of myomectomies before, you will know that in many instances, some of those myomectomy holes that you dig into, you repair some of them even 5 or 4 layers. So I believe in the past, why we were having some of those rupture is because people just say, oh, repair uterus in 2 layers, and they go ahead repairing those very thick muscles in 2 layers or even 3 with chromic. But I tell you, in modern practice, if you repair a classical incision on a uterus with Vicry in 4 layers, that uterus will not rupture. That's the reality. Take it up. Now, so I believe some of the ones that happen, and then you see such women know that they are still in their reproductive years, they need to the next baby. It's just like myomectomy. When you have done it, the woman shouldn't go ahead and be pregnant in 6 months, minimum of 1 year, and then they have to third. Some of them to book, they are already 28 weeks, or even when ruptured. Modern suturing, either as things have become better. Those days when it is just chromic, and then things just fall apart very early. Fibroid in CS. Well, I wish to announce to you that that's my area of special interest. And when I started doing it, I went also into literature, and I discovered that people near us in Benin have documented what they have done. I'm working on documenting the one we have also done in Oluyoro. I don't know whether they are up to 50 yet or whatever, but both the ones I did outside and the one in Oluyoro, I'm sure very soon they will be up to 50 or 100, and then we can publish our series. The biggest I've done, this woman booked in one of the private places where I cover in Ibadan, and the uterus, this fibroid was so big that all the other doctors that saw her said, no, they are not going to touch it, you have to come back 6 weeks. She actually even went to teaching hospital in Osogbo, and they told her, no way, if anybody does it, you are going to die. So she came back, because she knew, the way I talked to her, she knew this man is confident. Now, I wish to announce to the house that the uterus we remove, sorry, the fibroid we remove was about the size of the baby. Baby was about 3.5, fibroid was about 3.2. So I removed fibroid with uterus, and my obstetrician that work along with me anywhere, they respect me for it. They may not do it, but I will do it, and we are going to publish our results. And because check it, the closest I know outside Nigeria, within Nigeria, are the people in Benin. They've been doing it, they published their own result, and they are doing well. How do you do it? It's very simple and very straightforward. Now, I was not interested in doing it before, but the time I decided to start to do it was 2-3 occasions happened. We used to have gynae resident that used to come to cover for us, just for us to rest. And one night, one of them was about to do a cesarean section, and the fibroid was in lower segment. Opened the place and said, ask them to come and wake me. 2 a.m. Oga, I cannot know where I am going to deliver this baby, because the fibroid is in the lower segment. So in many instances, that's the reality. The fibroid is there. You can't, at worst, probably you have to do a classical to deliver that baby. So what are we going to do? We will not deliver the baby. The fibroid is on the way, and you can't go and deliver the baby before the fibroid. The fibroid is right in front of where you want to pass through. So it was after 2 or 3 were like that, and I said, hey, so if this thing is obstructing our way, what are we going to do? We are going to leave the baby there. It must come out. So subsequently, I got comfortable and very confident in doing it. And how do you do it, as my friend asked? First, if it is not on my way, I will first of all G31 deliver the baby that I've come to deliver. After I've delivered the baby, I will now start. If none is around where I will close the cesarean section incision, I will close the cesarean section incision. And I will say, praise God, we have delivered the baby, everybody is happy. So next stage, we now want to do, we have done obstetrics, let's now do gynecology. So, and with the new technique by which you do mammectomy, that you carry a catheter and tie, so you head, after you have done all the, given all the osteototics, you give, you probably, you are not, it's not available for you to yet give a misoprostol. But if you like, you can drop some misoprostol even inside the uterus and give all your osteototic. Uterus is now well contracted. Carry your catheter, tie that place, and then you can go ahead, do your mammectomy, and please do what I've said. After you have removed each of those holes, close them in not less than 3, 4, or 5 layers, and if possible, use Vicry number 2. That's how to solve the problem. So, and when you've the tourniquet, check tourniquet time. If it's so much that you need to release and retie, please do. Sure, it's available. If you need to massage and put hot massage on the uterus, please do it. So those are the things. Normal mammectomy, still do the same, even when it is mammectomy with cesarean section. I have discovered that it is fear that makes us to want to run away. I have never lost any of the patient. What happened is that one of them, in fact, that particular one was related to me, and I didn't want to do it, so I gave it to my colleague. But after they delivered the baby, the fibroid was so big that he called me and said, Oga, I cannot do it. You have to come and do it. Since you say you want to remove the fibroid, so I still went. We did. However, because the fibroid was already getting, it was already getting caseous, already getting degenerated. We removed it, but she bled and had to take several pints of blood, both intra-operative and post-operatively. So those are the things you prepare for. Prepare to give them blood because they are likely to bleed. But honestly speaking, you should not shy away, because what about if the fibroid is where you will deliver the baby? What will you do? You will not deliver the baby, or you will leave the fibroid there? So that was what the lesson or the confidence that took me to that journey. So I hope that I have helped you in both in technique and other things. Issue of ruptured uterus. If a uterus is ruptured, the book tells us if the uterus has been trying to complete something and is not able to complete it, and you have to repair it, the best thing is, if you are not taking that uterus out, you do a BTL. I do agree with you, sir. That is what the book tells us, and that is what is the best, because in most instances your repair may not be able to save the next one, since this uterus has been trying to do the function for it and it failed. It's likely to fail the next time. Internal polarity fraction, very important. In many instances, some of the ones that are deeply impacted you could easily put your hand and turn the baby or do breech delivery. But before you do it, if you are not skilled or you are not skillful, do the inverted one. Ensure you have an incision. It doesn't have to be so far up. Just ensure that you enlarge that incision sufficiently, so that when you are now bringing the leg down, you will not your lower segment will not tear to the end. That's the thing. In most instances, the legs are usually very much available, and all you need is for you to put your hand and be able to deliver number one. When you have delivered one, the second one will just almost find its way ready for you to deliver, and then you can now pull the whole baby out. But as much as possible, whichever one is available is what you should do. The caution is that even sometimes when you have the tear to those edges, all you need, in fact the last CS I did this last week, uterus was rotated. I thought by the time I had rotated it back, put my incision in the middle that I consider as middle, yet after it I discovered that boom, as I delivered the baby like this, the uterine on the left just tore. I did what I think I have never done before. I started repairing that uterus from that vessel, cut the two vessels together. When I made sure that it's already well secured, was when I started doing my repair. And I started doing it reverse. You know, we always start from the other side. No, I started from this side, and I did the repair, and the woman is fine. So that is why surgery is not dogma. Avoid dogma. This is how it's always done. Whatever you find in the patient should do. Shoulder dystocia. Thing is that you can we call it EPA phenomenon. First, you know that shoulder is hooked above the sacrum. Sorry, above the symphysis pubis. And the way you recognize it is that as the woman is contracting, the head will come out, and then as the contraction stop, the head will retreat. So we call it turtle sign. If you have seen Alabahun before, to bring out his head is it. So the woman contract, the head try to come out as if everything will come, and then when the thing stop, the head goes back. Possibly there is shoulder dystocia. The first thing you do is that you put pressure suprapubic, and in most instances the thing can come out. If it doesn't, The next thing that you are told that you can do is for you to now put the leg of the woman up. Put the two legs up. When you put the legs up and somebody put pressure for you anteriorly, most time it can come. If it does not come, then you do what is called the wood screw phenomenon. You have to put your hand to the posterior one and you push the shoulder to the opposite side so that the one on top can come off. So all of those, you try all those 3 or 4 procedure. When it doesn't happen, put the woman to be on her 4. That's the way some of the local people deliver these babies. If the woman is all her 4 on the ground, the whole place, that one that is hooking on the it will come off, and then you should be able to deliver. If you try all of them, it doesn't work, go and do cesarean section. Symphysiotomy is still practice. However, post-symphysiotomy care is one of the things that you may not be comfortable with, and most women will not accept that from you. I've just delivered, you must wrap something around me, I cannot go. They say even àwọn tó ṣiṣẹ́ fún, àwọn tó jẹ́ pé wọ́n iṣẹ́ náà ṣe fún wọn, wọ́n ti lọ, kí ló kàn tèmi? So that's why it's become very unpopular. So I will not advise you and me to do it, because the post-operative thing is what people are looking for. Like my friend said, when I first got to Okegbo, the first message people said, cesarean section, going home before before naming ceremony. Ifeolu, where does the man come from? Because what they knew around the area before was that sometimes 2 weeks cesarean section will not go home. And I said, what are they doing? They said they don't know. So my own 4 days, 5 days, the women are already walking about, and I decided before 8 or 7 days that they are doing naming. They say, where does this man come from? From space? So that's the kind of thing you will not want to put in your practice, that will not give you unnecessary name. But it's still done, it's still in the books, and it can be done. But whatever will not give us, especially in our rural setting, where they know you, they know me, we will not put such things afore. The use of surgical. Now we can go ahead. The bean leech stitch is similar to this corset that we use for trousers. After you have done, you just put it from the front, you go back, you tie it across. Come and tie it here. You go here again, from here in, out, go across the top again, you take it in and out. So you put them together and tie. So it more or less holds the whole uterus together. It's as simple as that. So, and then you can also go and stop the branch, the uterine branch of the femora. So they are near any of the, in fact, most of us that we have done cesarean section before, we will always see the vessel looking at us. All you need is just trace it back to where it is coming into the uterus and tie it there. When you tie it, it cannot go, it cannot continue to bleed. We may not have the surgical skill to go right down to the femora, to the iliac branch. All of those may be too far. But beside the uterus itself, right there, you see where the uterine artery is entering. Go outside the body of the uterus and tie it there. That's what I've done oftentimes. I usually don't go ahead dissecting that I'm looking for where it is coming from, the internal iliac. No, I've never done that. But out there, when you tie, is it the same thing? The bleeding will subside. And most instances, the uterus is so well vascularized that even when you do the two, that uterus will not die. That's the reality about it. It's so well vascularized and so well anastomosed that it will not die. It will still there, be there, but you will have solved the problem. Thank you very much. I think we have tried to cover.
Thank you very much, guest lecturer. We thank you for the job well done. So on behalf of ARSPON or your state, I would like Dr. Isa to come and please. Dr. Isa, please come and appreciate our guest lecturer on behalf of our.
On behalf of our sponsors, we really appreciate your presence and for the good lecture you have given. May God continue to be with you. And you see, so you journey to go back to our destination.
Thank you, sir. Then our next on the agenda, in the next 15 minutes, we are going to hear from the team fixing. From the team fixing. That means. So I would like to recognize the presence of Mr. Tolulope from Fixing Healthcare. You are welcome. And Mr. Tayo Deje also from Fixing, and Mrs. Damilola Dada. So in the next few minutes, they will be engaging us. They have something for us, and we are going to listen to them. Please, you are welcome on board. Thank you.
Thank you so much, sir. Yeah, 15 minutes each. Yes, thank you so much, sir. Good evening, sirs. Good evening, mass. Uh, my name is Tolu Lokwedada. I work with Fitting Healthcare PLC. It's a privilege to be here with you this evening once again, as I was last year in Ilaji. I'm glad to be in our midst again today. Please permit me to stay close to my system. I believe you could see me this way. So very briefly, I will run us through a discussion on the management of venous thromboembolism. The discussion will not take more than, like, let's say 8-10 minutes. I will try as much as possible to run with time. But a discussion proper, I would like to give a brief summary about the company I represent. Fitting Healthcare PLC is an indigenous company. We are publicly quoted. We are industry leaders into sales and marketing as well as manufacturing. We are ISO certified over the years with brands like Isenyin, Astifa, Ciprota. To mention a few of our brands, we've come to be tested and trusted. This is an overview to guide our discussion this evening, where we get to talk about the venous thromboembolism, the pharmacological agents involved. Then I'll get to talk about my drug of concern, which is cutaneous. Then the mechanism of action of it, the clinical data, the bioequivalence data, indications and dosage. I'll take our question, then I'll conclude in all. I know most of these things I have to talk about are not new to us. They are not by any way strange to us. So I just want to run through the prevalence part of it and run straight to my drug of focus, so I don't have to take much of our time. Venous thromboembolism is actually a major, but then preventable cause of death worldwide. We know it's composed of both the deep vein thrombosis and that of the pulmonary embolism. The prevalence of VTE cut across various patient groups. For we the surgeons, I know the percentage of the prevalence in our patients, we have as high as 40% in general surgery, equally as high as 40% in major gynecological surgery, even as high as 40% in major urological surgery, neurosurgery, and so on. This doesn't leave out the fact that in internal medicine as well, as high as 40% of as high as 20% of patients come down with VTE. But I'm very much concerned with the surgical cases, because then we are much more concerned about the surgeons in here today. We know equally, Dr. Okeda did mention had quite a presentation on us with O&G. So I want to equally digress into something that he discussed earlier, or something that has to do with what he discussed with us earlier, because then I know most of us in here, we have cases of CS and the like. So we've known for a fact that the prevalence of VT in pregnancy is higher in women who are pregnant as compared to those as compared to women who are not pregnant of similar age. And equally, the incidence appears to be highest in postpartum period. This is one reason why VTE is considered to be taken very seriously, because studies also conducted in African populations shows that 48 DVT per 100,000 births is being recorded yearly. That's just for DVT, not to mention of that of VTE in pregnancy. These are various risk factors that has to do with VTE. The risk factors includes, when we get to see patients increasing age above 40, increase patients being exposed to VTE. Equally, prolonged immobility, such as patients who are bedridden, prolonged hospital stays. This category of patients are also prone to having VTE. We have patients who have previous case of VTE, cancer, patients who had major surgery or trauma. Equally, for the obese patients, they are also prone to having VTE. For those who are having acute medical illness, hormone therapy and the likes, I would like to stop at this, even though we also have those who are smoking, the pregnancy and postpartum, as I said earlier. These are I have other categories of risk factors listed on our screen. But then the risk of VTE increases with number of risk factors seen in these categories of patients. I just want to run us through a typical. For patients who has an increasing age of above 40, for example, the risk of that patient coming down with VTE is about 11%, as we can see on the graph I'm showing. But then for patients who have more than one risk factor, let's say having the patient is above age of 40 and equally obese, such a patient is having two of these risk factors, they stand a 24% chance of coming down with VTE. So this is important to see that for a patient for a patient with four factor, let's say a patient who is above age of 40, and equally such a patient is having a long stay is bedridden, for example, a prolonged immobility, and such a patient is equally obese and having acute medical illness. That's 4. Such a patient will stand 50% chance of VTE. You can see how easy it is for the category of patients we see in our daily consultations, or patients who are on admission might come down with VTE. And for a patient who is having 5 of these risk factors, let's say increasing age of above 40, prolonged immobility, who has previous VTE or might not, who is to undergo a major surgery, and also is obese, and then having acute medical illness. This is 5 of these risk factors mentioned. Such a patient of coming with VTE. And then what are the therapy goals in management of VTE? 1, it's important we prevent the thrombus formation, that is the prophylaxis. It's better we prevent it from happening at all. Then secondly, for those who have actually had the episode already, we don't want a recurrence of such episode. So then we want to prevent recurrent VTE as well. And thirdly, to reduce mortality, as we know that the untreated pulmonary embolism has a high mortality as high as 70%. These are the therapeutic options that are available. Amongst them is a low molecular weight heparin. It is the mainstay prophylaxis because of the definite advantage it has over other form of therapeutic options that are listed. We are very much concerned with the low molecular weight heparins, and on this ground, equally the guidelines for the prophylaxis of VTE, you could see that in low risk, it's advised that the patient should undergo early ambulation, but then in moderate risks, low molecular weight heparin comes in handy. In high risk, low molecular weight heparin also comes in handy, and in highest risk, low molecular weight heparin comes in handy. You could see that across all the various risks, be it the moderate risks, the high risk, or the highest risk, low molecular weight heparin comes in as a treatment of choice for this category of patients. On that ground, I introduced to us Ketonos, a brand of low molecular weight heparin of choice from the stable of 15 Healthcare PLC. Running us through, I would just want to pinpoint the fact that there are established efficacy in medical patients. The frequency of VTE when we compare patients who are on placebo as compared with those who are being administered with enoxaparin quinones in this case, you could see that the incidence or the frequency of VTE is way reduced in these categories of patients. You could see that for patients on placebo, when in heart failures, for example, 14% of them are standard use of VTE as compared with 4% who are placed on ketones. For equally for patients on other various classes of diseases, they stand lesser frequency of VTE as compared with placebo. Equally for surgery, in prevention of DVT after hip fracture surgery, for patients who are being placed on enoxaparin as compared with other prophylaxis regimen, you could see that the prevalence of total DVT is way lower in those patients who are being treated with enoxaparin as compared with those who are on either placebo, aspirin, low dose heparin and the likes. For patients on enoxaparin, the prevalence is as low as 18% as compared with those who are on placebo who are 50%, those who are on aspirin who are 39% and low dose heparin who are 20%, as well as warfarin, which is standard 20% for total DVT, and then prevalence coming down to 6% for enoxaparin. In case of established efficacy in surgical patients, when we see surgical patients equally, you see that the prevalence of DVT with patients who are placed on enoxaparin is lower when treatment with ketones as compared with other regimen. With ketones, we have it as low as 5.3%, which is the lowest on this chart. As we can see, others are as high as 15%, 16%, and the likes. But then with ketones, these patients, the frequency of them coming down with DVT is as low as 5.3%. Equally, I know the questions I might have to face at the end of the presentation is what I want to just briefly deal with right now. There is comparison between patients who are being administered with ketones as compared with innovator brand of low molecular weight enoxaparin, the known clexane out there. I know for some prescribers they might probably be used to the use of clexane, but then we have studies to back the fact that our brand of low molecular weight enoxaparin is equivalent to the innovator brand, that is clexane. With we have studies and we have journals to back this fact up. Guys, when we compare the branded enoxaparin, that's from Sanofi, with that of our ketones in healthy human volunteers, as seen with the parameters seen over there, then with this hemostatic parameters seen, the result shows that no significant difference is seen in the various or hemostatic parameters when noted when either the clexane is used or ketones is being used, which makes it equivalent to the innovator brand. Equally, we try to compare other parameters as well, and we could see the result also shows that the two groups being compared are very much the anti-LI are very give same response. And then the WHO equally, ketones is internationally recognized by WHO and is recommended for inclusion in WHO model list of essential. These are the safety and tolerability of ketones in use in our patients. Fine, there might be some local effects which may include pain and the likes, but generally, in general, the hemorrhagic side effects occur in 3 to 7% of patients are seen, and then heparin-induced thrombocytopenia, and equally gastrointestinal side effects, which may include beef nausea and diarrhea. These are the indications for the use of ketones in our patients. In prevention of deep venous thrombosis after surgery, ketones should be used. For treatment of established DVT with or without pulmonary embolism, ketones should be used. In the prevention of clotting in extracorporeal circulation during hemodialysis, ketones should be used. And in prevention of DVT in trauma patients, ketones could be used amongst others. For prevention of deep vein thrombosis in patients who are bedridden, we know we have some category of patients that might be in hospital for like a week, 2 weeks, and the likes. Ketones should be administered to this category of patients for the fact that they are bedridden and immobile for a period of time. For the dosage, the indication determines the dosage to be used for the usage of ketones. In treatment of established DVT, we expect that 1 milligram per kg should be administered 12 hourly, and the treatment should not exceed 10 days. Equally, for the prophylaxis of DVT, be it in the moderate cases, 20 milligram once daily, while in high risk cases 40 milligram once daily should be administered. But then for the obese patients, this is where the 60 milligram comes in place for patients who have body weight above 150 kg. And the benefit that ketones gives to your patients is convenience once or twice daily dosing. Outpatient treatment option could be gotten with use of ketones equally. It has less effects on the activated partial antithromboplastin time. It has a more antithrombotic than the hemorrhagic effects. It has a better efficacy to safety ratio. Is readily available, and above all, which is something I know will be very much peculiar to we surgeons in the rural area, is very much cost effective even than the innovator brand, as we have established earlier with studies and journals to back up the fact that it's equivalent to the innovator brand, but then much more cost effective. So it's much more pocket friendly for our patients, especially in the rural area where cost be a big consideration when it comes to medication of choice. Thank you all for listening. I would like to take our question, and then I seek your commitment to the prescription on ketones. I hope I didn't get to spend minutes I plan spending. So please, I would like us to probably just note down our questions. So no, let me take the questions so we just answer it together. No, after. I will just take it together. Let me see.
Please, we should be jotting down our questions. So after the second presenter, then we can ask. So the second presenter, please. You are welcome on board.
Thank you very much for your audience so far. My name is Omotayo Dede, and I work with Fitnet Care PLC. I promote basically special formulations, mainly for fertility, reproductive health, and general well-being. Of course, my colleague has already introduced us, so I really don't need to do that more on that. But I also need to mention to us that one of our brands, Adizwa, has been around for over a period of 15 years and has been tested and trusted. M2 of course, has also proven efficacy beyond expectation. So, of course, building on that same pedestal, I'd like to introduce to us today one other brand from the stable of Fitnet. From the stable of Fitnet Care PLC, Immune. And of course, I know we are very the basics of the started from here. Let me see. So we are very, very familiar with the basic immune system functions. So I'm just going to put and introduce the brands to us. Well, the relevance of good immune system cannot be measured. And we know that the immune system is the soldier, the defense mechanism of the body. And as such, if a patient's immune system is compromised, patients are prone to infection, patients are prone to reduced function, but more importantly, antibiotic therapy is also likely to fall if patient's immune system. So the basic the basic causes, things that can lower, has been identified. Of course, children generally have a lower immune system because they are just developing and they are just developing their own immune system. But again, as we age, geriatrics generally have the tendency to have a lower immune system, and of course this is the main reason why this category of people are susceptible to different infection of different etiology. Then of course we've identified the issue of hormonal distortion, the issue of malnutrition, and of course certain drugs such as prednisolone can also predict patient to lowered immune system. Thank you. So the consequences are so numerous. For example, like I said before, instances such as cold and cold infections, minor infections such as cold and cold, will bring down this category of patients. And of course, healing takes longer, especially after a surgical procedure. it takes longer for the patients to heal, and of course, there is tendency for antibiotic therapy failure. Of course, which is one of the things we are fighting against globally, antimicrobial resistance. But in most cases, it could also be due to the level of the immune system. Then, of course, the patients are also prone to certain kind of cancers. Then, very importantly, I also want to make an analogy of the immune system and the HIV infection. Of course, we all know that infection battles mainly the immune system. It does this by generally destroying the CD4 cell count. So of course, when the CD4 cell count is depleted gradually, then the host defense mechanism is actually also depleted. So in order for us to combat compromised immune system, in order for us to help patients become immunocompetent, it is on this note that Fitzinet PLC brings to us a brand called Extra Immune. Extra Immune is actually a polyherbal formulation that comes in 2 dosage form. It comes as a syrup and of course as tablet. There are basically slight variation in the constituent, and of course which I'm going to be talking to us about. Basically, the syrup is actually formulated mainly to stimulate immune system, so it is much more appropriate for immunocompromised patients as well as pediatric patients. It has been clinically tested and has been shown that when we enhance the immune system of children, we generally reduce the level of absenteeism of these children in school, and we also reduce the instances of infection that they come back from school with. Then basically, the benefit of Extra Immune is that it, in addition to its ability to enhance the synthesis of CD4 cell count, Extra Immune can also help phagocytes to be easily mobilized to the site of infection. So it also reduces it also helps to exhibit potent antioxidant activity. Of course, this is one of the issues that occur, especially in aged patients. When you have a high amount of reactive oxygen species build up in the system, this tends to actually cause the death of cell, and in the long run, there is general reduction in cellular composition of the person. Now, Extra Immune as a monotherapy has also been found to be very, very useful in pyrexia of unknown origin. This it does by modulating the immune system to bring it to balance, and of course help the patient to reduce fever. Further on the benefit, Extra Immune has been known to potentiate antibiotic therapy. Of course, like we rightly said, when the immune system is compromised, there is bound to be antimicrobial failure. So when you administer Extra Immune, you tend to actually reduce this tendency for failure. It also helps to prevent recurrent infection. For example, a patient coming down with fungal infection recurrently can also benefit from boosting immunity, of course, from Extra Immune. Extra Immune can also help to combat resistance due to antimicrobial agent. So an appreciation of the ingredients that are used in the formulation of Extra Immune is as follows. We have inside it the likes of Tenospora cordifolia that has been established to be a potent antioxidant, and of course we have Curcuma longum, which has high anti-infective agents. So in addition to its ability to actually help boost the immune system, Curcuma longum has been found to have high anti-infective agent, although this should not be substituted for antimicrobial therapy. And of course we also have the likes of Raffia longo, which have potent antioxidant and anti-inflammatory activity. Like I said before, it comes in 2 dosage form, and it can be used prophylactically or therapeutically, depends on the physician's discretion. So if it is used therapeutically, the standard dosage is actually 2 tablets twice a day for the period of therapy. For example, if our antimicrobial therapy will take 5 to 10 days, we administer the tablet 2 tablets twice a day alongside with the antibiotic. But the syrup can be used at 15 ml twice a day, of course, for the same category of patients, adult and children alike. But prophylactically, the dosage can be used just once in a day for a period of about 3 to 6 months. But for some patients that are immunocompromised, this category of patients, the improvements in the CD4 cell count will determine how soon we can tell the patient to go on drug holiday. So, but then they will also benefit because it will significantly improve their CD4 cell count and generally improve their immune system. So basically, the efficacy has been extensively studied, and of course, it's been shown to actually help to enhance in the immunomodulatory activity of one of the ingredients, Temolena cebola, has been shown to extensively help to increase patients' phagocytic activity. And of course, there are also other ingredients such as the osimum sanctum, which has also been extensively studied, and the activity, antioxidant activity has been extensively studied, which has been shown to also help prolong the health of our CD4 cells. There's also Tinospora cordifolia, which, like I rightly mentioned before, in addition to its activity to help increase CD4, stimulate the production of CD4 cell count, it also has potent antioxidant activity, which helps to enhance cells' life. Then there is Glyceria glabra, which of course, this is one of the ingredients that has been studied, and of course, because of its effects on the endometrium, of course, it's been shown to contain glycerin, which of course has been studied to have some adverse effect on the endometrium. Of course, this is where some of the contraindication comes into being for patients that are pregnant. The ingredient Glyceriazine glabra actually contributes Glyceria, which in its pharmacological effects counter the formation of certain protein in the endometrium. Of course, this can affect implantation, so it is actually not advisable to administer the tablets to pregnant women. Like I said before, they contain some different composition. The Cyperus rudantus has also been extensively studied and has been shown to have certain antioxidant effects in addition to the ability to actually improve the immune system. And of course, we've also have documentation for Pepelogon and Aconiform heterophyllum. So this is actually the plant composition that is used in the formulation of extra immune. And of course, like my colleague rightly said, we are encouraging us to actually transfer the same trust we have for brands like Astimin, Asifa, Adizwa, M2tone to extra immune. Of course, the brands that guarantees patients body defense and of course reduce the likelihood of patient coming down with infection or the likelihood of antibiotic therapy failure. Once again, the standard dose is 2 tablets twice a day therapeutically for the period of therapy, and of course prophylactically is 2 tablets once a day for as long as determined by the physician. I'd like to say a very big thank you to you for listening, and we welcome all your questions. Thank you very much.
Thank you very much. I think we have just been introduced to another new drug from the table of Fixing Healthcare Limited. So, any questions regarding the 2 drugs they have just presented? Questions? Okay, okay.
Yeah, thank you for the presentation. I'm more interested in the extra moon. It looks quite interesting, and obviously